Dr. John Krakauer is next, and we'll pull up his slides. A little introduction of my friend and colleague, Dr. Krakauer. Dr. Krakauer is currently the John C. Malone Professor of Neurology, Neuroscience, and Physical Medicine and Rehabilitation, as well as the Director of the Brain Learning, Animation, and Movement Lab, the BLAM Lab, at the Johns Hopkins University School of Medicine. He is also a visiting scholar at the Champelli-Mode Center for the Unknown in Lisbon, Portugal, and external professor at the Santa Fe Institute. His areas of research interest are: 1, experimental and computational studies of motor control and motor learning in humans; 2, tracking long-term motor skill learning and its relation to higher cognitive processes such as decision-making; 3, prediction of motor recovery after stroke; 4, mechanisms of motor recovery after stroke in mouse and non-human primate models, as well as in humans; 5, new technology-based neurorestorative behavioral training in neurological conditions and aging. Dr. Krakauer is also co-founder of the company M2 Health, subsequently acquired by MindMaze, and of the creative engineering Hopkins-based project named Kata. Kata and M2 are both predicated on the idea that animal movement, based on real physics, is highly pleasurable, and that this pleasure is hugely heightened when the animal movement is under the control of your own movements. A simulated dolphin and other cetaceans developed by Kata has led to a therapeutic game, MindPod Dolphin, which is currently being tested around the world as a location-based digital therapeutic for various neurological conditions. Dr. Krakauer's book, Broken Movement, The Neurobiology of Motor Recovery After Stroke, was published by the MIT Press in November 2017. He received the Vista Award from the American Society of Neurorehabilitation in 2017. And I will just say, for the record, on a daily basis, it is a pleasure to work with John Krakauer, and I'm really looking forward to this session. John, take it away.
Can you hear me now?
Yes, we can.
And can you see my slides?
They are, but they're not in presenter mode.
Oh, sorry. Are they now?
Perfect.
Okay, so Dale, it was really nice to have you go before, because obviously there's going to be a lot of overlap. I'm not going to apologize for this talk being a little bit complicated. I don't expect it to be followed completely. I don't think I understand it fully myself. But I do want to give a sense of how difficult this is, and also to point out this very mysterious difference between humans and even other non-human primates, and how challenging it is to do work in humans and then find a way to relate them to the animal work. Okay, so, and I'll skip certain slides because of what's already come before, but just let this wash over you. Don't try and understand all the intricacies, because it's a lot. This is our website, BLAM, that's the book. A lot of the arguments in that book, although of course they've been updated. That's already 5 years old, which makes me shudder. Maybe I'm going to have a second edition. Somebody else can do it, maybe. So I'm going to talk about the complexity of the hemiparesis phenotype cross-sectionally and longitudinally. And one thing I'm going to say is I'm going to talk mainly about the arm. The hand is a complementary story. There are similarities when it comes to the arm and the hand for the story I'm going to tell, but I'm not going to talk about the hand. That would require another talk entirely. And also, you know, some of the interventions that we're going to need for the hand. I hope that Omar Ahmad, who's been instrumental in really thinking about how to build new software and hardware for the hand, mentions. I'm going to just talk about the fact that stroke in humans is really, really hard. And one of the reasons it's really, really hard is, unlike in the animal models, it's not just a deficit disorder, it's a movement disorder. And in fact, the term extrapyramidal, which is now used for movement disorders, actually came from studies in the monkey. So there was acknowledgement, even though it was by accident, that there was a movement disorder lurking in human stroke that could not be found in the monkey models. Basically, Hewlings-Jackson talked about this at the end of the 19th century, talking about negative versus positive signs. And then the neurologist F.R.R. Walsh was more explicit, even in the case of stroke, talking about the dual nature of hemiplegia being this combination of loss of voluntary movement than the intrusion of positive phenomena, spasticity and synergies. And one of the sort of interesting ironies of the history of rehab is, the rehabilitation has been very interested for good reason in these intrusive positive phenomena that really don't get mentioned almost at all in the animal models, which is not a criticism so much as the fact that it's lacking. As I said, that's why the word extrapyramidal came up, because people said they must be somewhere other than in the pyramidal tract. And for those of you who aren't fully aware, the pyramidal tract is essentially the same as the cortical spinal tract. So I'm going to show you what hemiparesis looks like, and I'm going to dissect it more than you're probably used to. And I'm going to think that that's incredibly important. Just like you would never say anymore Parkinson's disease as a blanket term, you would mention postural instability, rigidity, tremor, and bradykinesia as separate components of the Parkinson's phenotype, which, as you well know, respond differently to both DOPA, to DBS, and other medications. And stroke, unfortunately, is going to be more like Parkinson's disease, that you're going to have to worry about the component processes. This is a patient that we've all seen. Let's call this a moderate to severe patient at rest with this classic flexor bias at rest. And the problem with this being stuck after stroke in this place is that you can then get all sorts of secondary peripheral changes. You can get loss of muscle through atrophy, you can get contractures, you can get fibrosis in muscle, you can get all sorts of peripheral encasements of your neural deficit that make it really difficult to reverse the neural deficit, because you're now in this encapsulated in these peripheral disorders as well. So what we all want, obviously, is to prevent patients ever getting stuck in this place. But then obviously what we also want is a way to do something even for these patients. And I'm sure you'll hear a little bit about some of these peripheral effects to sort of release patients from them from Dr. Raghavan tomorrow, maybe. One of the most important things that we need is natural history studies of the components. We now have technology and ways to do better than Twitchell did in 1951. It's actually quite sad in a way that there haven't been follow-up natural history studies of the kind that he started back in 51 in 25 patients. And of course, we've tried at Hopkins with SMARTS-1 to sort of recapitulate these kind of natural history studies. I can't emphasize enough how important it is to do them now with our new approaches. So what he basically did is he tried to sort of see whether there was any stereotypy to the progress of a patient after stroke. And he came up with his sequence. So in other words, initially you're plegic, then you begin to get some flexion at the shoulder, then you get some flexion at the elbow, and then if you're lucky, you maybe get some flexions down at the wrist, which you can begin to see. Number 3 looks a little bit like that patient that I showed you before. So in a sense, you want to try and not get stuck at stage 3, and then you can get this other synergy that begins to express itself, which is extensor. In other words, it's an opposite one at the shoulder and elbow. And then if you can get through this sequence and begin to make out of synergy movements, in other words, one idea here is that the cortical spinal tract begins to switch back on and can operate on top of whatever descending system, probably the reticular spinal system, that is responsible for the initial synergies. And then what you really want then is, of course, finger individuation. Now, this is not entirely fixed. In other words, there's significant variability within patients, but overall, there's this main effect. And what we really want to do is to stop patients not getting through till 6. And we also want to know what the biology of this process is. And it's extremely difficult to work out what the biology of this process is. I'm sorry. So those are the intrusive symptoms, right? These flexor and extensor biases that are present, as I showed you, at rest, and also during voluntary movement, which is the ones that Twitchell emphasized. Then there's spasticity. I won't talk about spasticity. It's a very contentious subject. It's not clear that spasticity really is that important when it comes to its effect on voluntary movement for the upper limb, but I'm not going to talk about that today. And then there are the negative symptoms that Hewlins-Jackson's talked about. And you can basically look, what you need to do to get those in isolation of compensation, weakness, and positive intrusive symptoms is you need to isolate them. And there are 2 ways to isolate them. You can either isolate the proximal arm and try and get its dexterity assayed, or you can do the hand. As I said, I'm not going to talk about the too much today. So, these are setups that are used quite frequently. There is a reason behind this. In other words, what you're trying to do by putting a patient in a setup like this is you're trying to minimize the effects of gravity by having their arm supported. You're trying to remove friction with an air sled. You have the back of the chair up against their back strongly so they can't make compensatory truncal movements. And then you make the arm and shoulder, the elbow and shoulder planar so that you only have one XY coordinate in extrinsic space for a single set of angles at the elbow and shoulder. So in other words, there's no chance of uncoupling joint space from extrinsic space when you're planar, which means that you can't compensate. Okay, so in other words, you're doing your best here to isolate the ability to individuate the joints around the elbow and shoulder so that you can get straight trajectories that show low variance at the target. All right, so think of this as individuating your arm rather than individuating your digits. And we think that this is heavily cortical spinal tract dependent. And here's a classic stroke patient who's showing increased curvature, increased variability, and decreased accuracy to targets. And what you really want to do is to get from the right to the left. And there are ways mathematically to come up with a scalar measure, which allows you to say exactly how far you are in arm dexterity space from normal. And in a nice paper by Juan Camilo Cortez, who was the lead author, he basically took a look at some of these data and plotted this scalar measure in arm dexterity space where the lumbar is larger on the y-axis, the worse you are, and unfortunately showed that there was a window somewhat along the lines of what Dale was talking about, where this dexterity basically bottoms out around 4 to 5 weeks after stroke. And it's interesting, I don't have the plot here, but that is not what you see for things like the Fugl-Meyer and for strength and for other functional measures. So here you see a very clear dissociation, if you properly behaviorally isolate it, of the dexterity plateauing before other measures of function or strength or even synergies. And this is not a sensitivity measure. Please see there's a huge white space here, and down here you see the controls. So there's no sensitivity measure here. If the patients could improve, we would have caught it. Okay, and this isn't very different from what Gert Quackel has shown for another kind of prehension movement, where the window there seems to close around 8 weeks. Okay, and there does seem to probably be an interaction between window length and severity. So in other words, you have a little longer if you're very severe. That's why you might see the window close around 8 weeks, whereas it closes, you get basically reach plateau much faster if you're mild. So in other words, so far you've heard about resting abnormalities in that picture. You've seen Twitchell's voluntary abnormalities. You've seen these just dexterity abnormalities. And now you can begin to see that they all dissociate. Here's an experiment done by Alkis Hadjoseph, a postdoc in the lab. And basically here you're trying to use a quantitative planar approach to look at resting abnormalities. So basically a robot will passively move the arm across the workspace. You tell the patient to relax. If any of you do it, you'll just simply hold the manipulandum and you'll exert no forces on it. But patients actually have these resting flexor biases that they can't switch off. So basically here you can see a heat map where the vector, the arrows show the magnitude of the flexor bias. The patient will be down here. And so you can see their left paretic arm, even when they're being told to relax and they didn't even voluntarily move, has this big flexor bias. Okay, and you don't see it, of course, on the other side. Interestingly, when you give them weight support, in other words, this is when they were being asked to support the weight of their arm in a plane, when they get weight support, they still express these flexor synergies, but they're greatly diminished. Okay, so here you see quite dramatic, even with arm support, flexor biases at rest, even when they're being asked to relax and not move. Okay. And interestingly, you can quantify this and you can basically take a look at particular positions in the planar workspace, distally and proximally, with support and without support. You can look at the average resting postural force that I was showing you in the flexor direction on the y-axis, and then you can relate this to the Fugl-Meyer score, which was the score devised by Fugl-Meyer to quantify Twitchell's sequence. Okay, so the Fugl-Meyer score, as you all know who've done it, that is a score that is primarily done during movement. It was meant to quantify Twitchell's synergies. And now it's actually being related to the resting postural force. And as you can see, there's a very strong relationship. And you can see also that there's a change in the magnitude of the resting postural force with and without support. And interestingly, also, when you look down here, you can see that this effect is happening on the unaffected side as well in comparison to controls. But the real problem, obviously, is in the affected side, and you can see this modulation with weight support. Okay, so you see this and you go, okay, there's a correlation between a movement disorder during voluntary movement and a resting abnormality. That sounds good. We should maybe treat one, we'll get a benefit to the other. And that was actually the thought when you look at the ways of doing rehabilitation that were inspired by Twitchell and Fugl-Meyer, for example, by Agnes Brunstrom in her book written in the 70s. She actually was a lecturer at Columbia. They thought that if you took care of the resting abnormalities, the voluntary abnormalities would go with them. And as we now know, that doesn't happen. So it's very important to think a little bit more carefully about this distinction between moving, stopping, and holding still. And it's important to understand that any movement has its initial ballistic phase, its deceleratory phase, its stabilization phase, and then this holding still after movement phase, which is what was asked by Alkes for the patients to do, when in fact the blue and the red were truncated altogether. They were just passively moved into the green zone. Okay, and so this is a healthy subject, and here you see a patient with this ballistic phase, the deceleration phase, and then the holding still phase. And what I just showed you is that in this green phase, they can't switch off. Okay, and then you have to ask yourself whether that failure to switch off in the green phase has consequences for the blue and the red phases. Okay, so this is a rather elaborate figure. Again, I'm just going to give you punchlines rather than having you try to pore over them. But what Alkes did very meticulously was to basically quantify these abnormalities at rest, take a look at abnormalities during reaching, and then see whether you could actually show that these quite dramatic resting forces, were they having any influence? Were they revealing themselves in the landscape when you reached through them? It would be like flying through turbulence, right? And basically, he did a very nice analysis where he looked at in the workspace per patient and found where the flexor biases were least active and when they were the most active, and then took a look whether there was any differential deterioration in the quality of voluntary trajectories when they traversed the worst and the best parts of resting postural space, okay? And basically, the bottom line is no. So in other words, despite the dramatic presence of these abnormalities at rest, one could see no influence of them during voluntary movement. It wasn't that voluntary movement was normal, it's just it wasn't being modulated by a resting bias that correlates, by the way, with the Fugl-Meyer. So the mystery deepens in a way. Okay. Now, I'm not going to ask forgiveness for how intricate all this is, because this is precisely the level of detail that's going to be required, in my view, if we're going to actually come up with the next generation of interventions for patients with stroke. Interestingly, you could say, well, maybe those resting postural biases are an artifact of reaching passively with a manipulandum across the workspace, and they don't really exist when a patient voluntarily moves and comes to rest. So Alkes did another experiment where he showed that these resting postural forces actually switch on after a voluntary movement in stroke patients. And one way that you can probe for those is you can actually perturb movements at different phases of the movement and including at the end. And basically, I'll give you the punchline again. What's really interesting is that these flexor biases switch on after the patient comes fully to rest, but not during their actual movement. And you can actually reveal their existence by them being either beneficial or detrimental to a perturbation if the perturbation is either against or in line with the perturbation. So this was a clever way that Alkes actually probed for the existence of this movement abnormality that switches on only when the movement gets into the green phase, but is not present in the acceleratory or in the deceleration phase of a movement. This is extremely important. Again, it's like spasticity, that, if you were to take care of these abnormalities at rest, it's not in fact helping you with the abnormalities you have during movement. So what's going on here? Well, actually, Reza Shadmir wrote a very nice review article a few years ago, reviewing in the physiology of movement that there are hints that there are distinct neural circuits for the control of movement and the control of holding still. And stroke, in a sense, in an Alkis's study, is a wonderful way of checking on this, because you can actually see in patients who we know have disorders of movement and of holding still, what is the relationship between moving and holding still? And as I just showed you, they do indeed seem to be independent behaviorally. Okay, let's be very clear. That doesn't mean that the circuits dedicated to these modes of control don't share overlapping substrate. I think it's extremely important not to conflate those two things. Just to show you one more uncoupling, this is a paper that Alkis just published this year in conjunction with me, Pablo, and others, was to really take a look at this dexterity measure that I talked to you about and see how that relates to the Fugl-Meyer, which, as I said again, was made to quantify synergy during movement. And you can see these trajectories and controls. These are chronic patients with their Fugl-Meyer scores above. As you know, the higher the Fugl-Meyer score, the better you are. These are the trajectories, these are the scores. And then what Alkis did is, along with Merrick Branscheid, is they matched the Fugl-Meyers in the chronic and acute state. And you can see something very interesting here, which is even though in the acute state, subacute state, under 3 months, that the Fugl-Meyers are actually better in these patients compared to these matched ones up here, their trajectories were much worse. So here again, you're seeing not just a dissociation, as I showed you before, between resting abnormalities and voluntary abnormalities. Now you're seeing dissociation between voluntary abnormalities in the synergy space versus voluntary abnormalities in the dexterity space. And this is just it tabulated. So very complicated, right? And this is something that is disturbing in a way, because it suggests we're going to have to think how we can either target these abnormalities individually or come up with really intelligent, holistic interventions that actually get all of them, right? Now, what's explaining all this? So I'm just going to show you very quickly a study, so essentially what we have to understand is this anatomy and physiology of the motor system. And we've heard about the cortical spinal tract, which we see here, which is the primary, monosynaptic and polysynaptic pathway coming from the motor cortex and other areas, and decussating in the medulla, and then synapsing in the ventral horn. And then we also have what's called the cortical reticular tract, which is a much more mysterious pathway that is both bicortical in origin. In other words, it comes from old M1, new M1, premotor cortex, comes from both sides. It both projects down ipsilaterally and contralaterally. And this is very much the pathway that people think is important for both generation of high levels of strength in the healthy subjects and for the generation of these flexor synergies in patients. Okay, so there's been this idea that basically you suffer from having something available for voluntary movement, but it's not as individuated as the cortical spinal tract, and that's why you see synergies. But interestingly enough, and this is a study that we did using TMS with John Rothwell in London and Ulrike Hammerbeck, where we wanted to see whether the abnormality in synergies as measured with the Fugl-Meyer could actually be attributed to a TMS-evoked measure of upregulation of the reticular spinal tract. And interestingly, in patients subacutely, even though they had synergies, there was no evidence for upregulation of the cortical spinal tract, the reticular spinal tract, okay? Which is unlike what is seen in chronic patients where you do see evidence for upregulation of the reticular spinal tract, but you don't see it in the subacute space, even though you see an abnormal Fugl-Meyer. So what this suggests is before you get plastic changes in descending pathways, physiological imbalance alone can probably explain these abnormalities. Okay, another reason to perhaps go early with interventions before physiological imbalance turns into structural imbalance. Okay. Now, all of that I've told you, okay, all these studies that have been done by us and others doing this meticulous dissection of the paretic phenotype and all its dissociations is going to have to be done all over again in 3D. Because the arm in 3D is quite different from the arm in 2D. So we're lucky that we've been working now with Ashish Deshpande, an engineer at University UT Austin, and we're getting this robot delivered, I think, next week. And we've begun to customize this 3D robot to try and perform very similar studies to the ones that, for example, by Alkis and also by Juan Camilo Cortez, that we're going to start doing this in 3D. And it could well be that the biology of the system under 3D movements, where you're obviously having to do weight support, is quite different. And again, one is going to have to come up with interventions in 3D to match, I think, what will be undeniable complexity when you go into 3D. And I don't have time to talk about some of the stuff we've already started in that area. So, okay. So how about all these components? How do they compare in non-human animals? Well, we definitely have motor control abnormalities in all the negative symptoms in all the animal models. So what this means, the ruler means, can you measure it? And these tools mean, can you fix it? Okay. And you definitely have weakness in all the models. And you definitely get compensation in all the models. And you can actually get these deficits in control, strength, and compensation. You can actually do something about them in studies in the mouse and the monkey. It's been very challenging, however, to show evidence of synergies in either mice, rats, or monkeys. So the positive symptoms that are of huge interest to therapists, to the rehab profession, spasticity, synergies, postural abnormalities, don't really see them, right? Again, speaking a little bit to their dissociability, not just within humans, but also in terms of the biology of these three mammalian species, okay? So I am actually speaking to you right now from Newcastle, from Stuart Baker's lab in England, where we actually have a grant to actually address this problem of not applicable, not applicable. Now, this is a complicated story, of course, and I'm simply going to tell you that one has to spend a lot of time looking at 100 years of experiments in non-human primates to begin to try and get some sort of insight into what the problem is here. Most of the primate research that was done trying to mimic stroke was done with pyramidal tract lesions. In other words, you go to the medullary pyramids and you do what is thought to be a fairly pure cortical spinal tract lesion. And that's why the synergies didn't appear, hence the term extrapyramidal. So where is extrapyramidal? Well, if you look at the literature very carefully, including specifically looking at some work that was done by Denny Brown in the mid-20th century, and he wrote a monograph in 1948, which I turgid as can be, but I actually made myself read, and it began to become apparent that the extrapyramidal site might actually be in cortex. You know, there's a small world that Denny Brown was actually a mentor to Thomas Twitchell, who looked at synergy. So we've come full circle. Now, one of the interesting ideas that came from the work by Denny Brown and by others was that there may be a region of the cortex, area 4S, which lies in the anterior old M1, that might be actually suppressing unwanted flexor synergies. It was actually called the suppressor region. Okay. So in other words, if you want to start seeing where synergies went, you have to start looking at new M1, old M1, 4S, perhaps in combination with other lesions, including pyramidal tract lesions, and actually I'll talk to you in a minute, rubrospinal lesions. And I'll just say that one of the interesting things that is being suggested by the work, and it's all very preliminary, I'm actually looking at new data today and tomorrow, is that in fact there is evidence in a monkey making reaching movements, despite fairly normal kinematics, that there may be some evidence for some flexor EMG turning on over time and co-activation in, for example, supraspinatus, anterior deltoid, and bicep, but much, much milder than in humans. And the operating theory we have right now is that even though there is evidence for failure of this suppressor region, the reason you don't see it in the kinematics is because in monkeys, unlike in humans, you have a strong ruberospinal tract that can override through an effect on extensors, the effect you're seeing in flexors. Okay, so watch this space. We're continuing to do these experiments, but we're hoping that we'll be able to actually come up with both a neural mechanism and a model for synergies in an animal model. Okay, switching a little bit. I know Dale talked about critical window. I'm going to show very quickly, many of you may know about these results, but this is work by Steve Zeiler and in his lab that we did in collaboration, where we basically wanted to see whether we could find a window in rodents. Again, it's extremely important to worry about homology. You've already seen some failures of overlap between animal and humans, and you always have to worry about evolutionary homology. Kolb and Weishaw, I think colleagues of Dale's, have made a nice case, I think, for at least behavioral homology for prehension in the rat and the human, and likewise the mouse. Here's a mouse trying prehension. This is a video from Steve Zeiler. This is when the mouse is really not very good. It can get much better than this and pick up the pellet and do it in one smooth movement and not have bad table manners and use its tongue like that. You can then make a lesion, endothelin 1 lesion in the motor cortex in the mouse. And then you see this lesion there. So in other words, this is a cortical lesion. Prehension in the mouse and the rodent is strictly cortical. Without cortex, they cannot do these kind of movements. You know, relating a little bit to what was spoken about, you don't really see spontaneous recovery of prehension in rodents. You see spontaneous recovery of many other types of movement, but these cortically dependent learned movements really need to be trained back rather than just spontaneously recover. So here you have the getting up to about 60% efficacy, and then you see the stroke. And there's some very important things in this lovely data that Steve produced, which is that you do see a little bit of improvement here, and then it flatlines far away from where they were before the lesion. And it's very important to see that they've been given more than enough time to compensate, right? So in other words, if they were going to compensate their way out of trouble, they would have learned that after weeks and weeks of training. Okay. So it's extremely important to realize that this task, the way it's been assayed, you really need to actually do it properly again in order to get right back to that. You can't compensate your way back to about 55% efficacy. But if you don't wait, this is the critical period result, you get yourself back to normal if you don't wait those 7 days, which is basically the length of stay, in fact, a little bit longer on an acute stroke unit for humans. Okay. So in the mouse, you shouldn't even wait a day. As I showed you in the work by Juan Camillo, you've probably got 4 to 5 to 8 weeks in humans. And then this is the study we always like to show, which is that if this is a sensitive period related to the onset of ischemia, then you can do something kind of cool. And Steve did this, which is basically do that experiment again, but now wait again, but now give a second stroke in a motor region. And of course, you're going to have a deficit, you have a bigger infarct. And then very interestingly, you can train the mouse back to normal if you don't wait the way you did here and you repeat the early window that I showed in the previous experiment. Now, there are a number of things here that are very important, right? So in other words, you train, you have a deficit, you get a little bit of an increase, then you flatline, then you have another stroke and you are worse, right? And then in a much shorter period of time, you can train back to normal. Okay. So in other words, you had a short period of time here to get to normal. If this were compensation, you should have done it in the 3 weeks you had available here, and certainly not after you're even worse. Okay, so in other words, for many reasons, the only real parsimonious explanation for this result is that you got true restitution of behavior through a training effect interacting with enhanced plasticity. And it's not non-specific. You know, Steve in the lab did the controls. They made strokes that were non-motor, and you get no such effect. So in other words, it's not some non-specific motivational effect that then again works through compensation. No such thing happens. Okay. And a similar experiment was actually done and got, you know, not enough attention in my view by a Japanese group back in 2008. In the interest of time, I'm not going to go through it in great detail. It's suffice to say that they looked at normal movements in pink versus compensatory movements in green and yellow. And then they took two monkeys with large cortical lesions, and there they trained them on a pellet retrieval task. And pink means that you're making normal movements, yellow and green are compensatory movements. Pink here is pre-lesion, and they basically followed out over well over a month. In this top monkey, they were trained specifically to try and make the non-compensatory pink movement, whereas this is a monkey just spontaneously recovering and doing its own thing. Okay, and it's extremely important to see that early on there's compensation in the monkey that is being trained. You need some spontaneous recovery of the behavior, and then you jump on that spontaneous recovery, and then you train it. So in other words, this is extremely important that you have spontaneous recovery that you take full advantage of, right? And it's very important to realize that if you take full advantage of this spontaneous recovery and train on top of it, you will suffer at the task level. So notice how this monkey actually, when it switches from compensatory to more pink, it worsens in its behavior. Whereas the monkey that was allowed to spontaneously recover and train itself, it actually has a period of time where it's superior to the trained monkey. Now, I say this, and I don't mean it in a critical way. This is unfortunately what most rehab encourages, because you don't want somebody getting worse at the task level for large numbers of days and have to wait for them to see at a delay the benefit of training to the impairment. But what I would say is what these studies are telling us, whether in humans or in rodents or in primates, is you must focus on impairment early, even if you have failure at the functional level for a while. You just have to live with that. You can always train function later, which is exactly what happened in this monkey. So an incredibly important lesson here, which is focus on impairment and allow function to worsen. That's how the window should be used, in my view. Okay, so this is from Dale's review, which I always like to use, and basically, you know, say that all the stuff you've heard from Dale and heard from me and from others is suggesting that we need to do three things, especially early after stroke. We need to create enriched environments. You've heard about that from Dale. You need to induce cardiovascular exercise, and you need to find a way to do capacity training for impairment rather than task level training. So the real puzzle is to do A, B, and C, okay, in humans. I'm not going to talk about enriched environments. You heard enough about that from Dale. So I was lucky enough to meet two people when I first got to Hopkins, Omar Ahmad and Primate Roy, who basically provided the inspiration to actually find a way to do this kind of enrichment in humans. But not just do the background enrichment, but also do the training in the front, which was capacity-based. In other words, in humans, could we find a way through what we call neuroanimation, get the enriched background and the capacity impairment-based training in the foreground simultaneously? And that's really what the mandate was for the Carter Design Studio that we set up in the Neurology department, led by Dr. Omar Ahmad, was to really do that, right? Could we do that? And I have to say that my belief is they created gorgeous enriched environments and training. And that's what I think human beings deserve, because that way we won't have a world where the rodents get better treatment after stroke than humans do. And so what Omar and the team made was a gorgeous oceanic environment with a beautiful simulated cetacean, and this is Bandit the dolphin, where we were actually wanted, and I'm not going to go into great detail today about it, but the idea is you wanted to find a way to motivate a patient in 3D to make capacity-based movements that were challenging and were simultaneously cognitively challenging, cardiovascularly challenging, and required skill. And the real beauty here was that the way that Omar and the team created Bandit was that there really was a titrated skill requirement that you had to follow in addition to just making macro movements and be cardiovascularly challenged. And that was the sort of secret play source that I think is really important to recapitulate what we see in animal models. And this is just one main result, is that when you compared patients getting either an intense high dose dolphin therapy, or, to be fair, extra hours of upper limb therapy. In other words, what happened here is that patients got an hour in the morning time on task, an hour in the afternoon time on task, 5 days a week for 3 weeks. And they did that either by having therapists give a lot more time, like a Nick Ward study, or they did it with Bandit the dolphin. This is a pilot study. There's a 150 patient study ongoing in New Zealand, going even earlier, within a week of stroke, led by Kathy Stinia and Winston Biblow. They've recruited about 24 patients at this point. We'll see what happens. But unequivocally, what this shows is more is better. And it shows that using technology is at least in equipoise with giving a lot more time to therapists. And my prediction is that for impairment-based treatment, technology will be a tipping point, and then therapists and rehab will be doing, I think, what they're really meant to do, and they do really well, which is focus on function. But serially, not in parallel. So, okay, so I'm just going to finish by talking a little bit about some neuroscience, because this is a lot of material, I know. I've hinted at, the interplay between the reticular spinal tract and the cortical spinal tract. But what do we really know about what the plasticity processes are going on here? So Tamar Macon, Jon Dietrichson, and I wrote a large chapter in the cognitive neurosciences called Reorganization in Adult Primate Sensory Motor Cortex. Does it really happen? No, it does not. So all you've heard about remapping and reorganization, and you've heard it from me, unfortunately, it's essentially wrong. Okay, so we have to find a new story to tell about how this is all happening. And, these are just some examples. These are the classic studies by Randy Nudo, where a subtotal lesion was made in the hand area, pre-infarct and post-infarct. You see this reduction in the area, and then you see some expansion of representations, which you can quantify, percent change from baseline. What people don't realize is actually there were 3 versions of this experiment: a rehabilitation version, a training-related version, a spontaneous version, and a delayed rehabilitation version. And in all 3 cases, you saw differences in map expansion. In fact, you only saw map expansion in the rehabilitation case, not in the spontaneous case, and not in the delayed rehabilitation case. They all recovered in the same way. Okay, so in other words, these map shrinkages and expansions are epiphenomenal. And we, in a recent study by Merit Branscheit and Naveed Ijaz, which we published this year, showed a very similar result using resting state over a year in patients with subcortical lesions recovering from stroke. And here you see very dramatic recovery in red. In other words, there's no subtlety in their recovery. And these are measures, a multivariate measure based on a pairwise comparison of interactions between a series of ROIs that we pre-specified based on a lot of the literature. And basically what you really need to be seeing here is that there was absolutely no change or evidence of reorganization in M1 or anywhere else for that matter as this recovery was taking place. And their connectivity weights vector looked exactly the same over time as controls imaged over the same time period. So I don't have time to go into it today, but essentially, whether it's primate literature, human literature, even rodent literature, for example, by Teresa Jones and others, there is no evidence that any cortical reorganization or map changes or plasticity is happening. Okay? So what on earth is going on then? Well, I'll give you one example. I talk about this in the book. This is a work by Warren Darling, who basically looked at the strength of connections down into the ventral horn in primates given large M1 and lateral premotor cortex lesions, and then looking at projections, pre-existing connections out of the supplementary motor area, and showed strengthening, in other words, gain increases of the connections of pre-existing connections. In other words, it's not an east-west cortical story, it's a north-south gain increase, pre-existing architecture. Nothing is reorganized, it was always there. And so we came up with a sort of formula for this in the book back in 2017, which is if you want true behavioral restitution, you need to have a dose of capacity training. You need residual pre-existing, i.e. non-reorganized representations like the supplementary motor area. And then you need to have conditions of plasticity, changes in inhibitory and excitatory balance, and then you multiply them. So for example, if you have a nudo experiment and you're early and your representation is quite large because you've done a subtotal lesion in the M1 hand area, you're early, so you have a heightened plasticity, you're going to get quite good spontaneous recovery. So it's not such a surprise that those monkeys that didn't get the training in the end ended up at the same place as those that did, because they had lots of representation, so they could use the plasticity for spontaneous recovery. But as you lose representation, as the window begins to close, you're going to have to chop things up with behavior. Okay? And I challenge anyone to give me any data so far in any of the literatures that don't follow this simple heuristic equation. So what are the implications of this north-south story for chronic stroke? In other words, what we're going to really need to do is stop worrying about all these cortical connections. Work that we've done with Pablo Selnik on interhemispheric inhibition showed that there was no cigar there either. So what we're really going to need to do is almost treat stroke as though it's spinal cord injury. Okay, a supratentorial spinal injury. And so that's led to a paper that we've just written, a position paper, on saying that maybe what we need to do is take a feather out of the cap of spinal cord injury and start doing implantable cervical epidural stimulation for stroke. Okay, now, the idea is that perhaps you can actually enhance the capacity of the residual descending pathways so that the spinal cord gets a less degraded signal. I'm not going to go into all the details now about the different theories. They're down here on the left. This paper's now in press at TINS, where we make this argument, and you can find it soon. Okay, but the idea is that we're going to take the north-south story. We're going to basically consider stroke the consequence of an imbalance between cortical spinal control and reticular spinal control, and we're going to try and give power back to the cortical spinal tract by cervical cord stimulation with implantable electrodes. And basically, I'm just going to tell you that we've done this now in 2 patients with quite severe chronic hemiparesis. And basically, these electrodes lie along the posterolateral surface of the spinal cord. And you can actually show through interrogating the H reflex that you've got activity in all the requisite muscles, which you can see on the right. I'm going through this fast, but again, we can always talk about this offline. And then you can do a very intricate dissection in these patients with these electrodes in their cervical cord of exactly the kind that I started with. In other words, you look at strength, and you can see quite dramatic, as soon as you switch on the stimulator, increases in strength in both extension and flexion. You can do very good kinematic analysis, and again, you see improvements in kinematics. In other words, you're seeing improvement at the level of strength. Here, you're seeing improvements at the level of kinematics. This is now on medRxiv. It's under review. You can take a look at it. And you can also see at the level of function. Okay, so you can see an ARAT-like task improving. Okay, so in other words, I hope you can see how exciting this is. And this is actually with it switched on. The final point I'll make is in order for us to get these gains without the stimulator on, in other words, they go away as soon as you turn the stimulator off, is I think, and we now have NIH funding to combine neuroanimation with the electrode on, stimulator on, so that we could perhaps begin to have these gains once the stimulator is turned off. So I will finish just by saying that this is a lot of work. It requires large numbers of people to be involved. I just want to say that, the neuroscience, the clinical trials, the funding require all that you see. But I just want to finish by saying the most important thing is that even exciting things like cervical cord stimulators, none of these new technologies, in my view, are going to work without high intensity, high dose, capacity-oriented training that is sufficiently holistic and multifaceted at the same time to actually have an effect on all the components. And so that requires, in my view, a very different sort of team. And I do not think that the effects we're going to see, for example, in the trial now with the cervical cord stimulation, will work unless we create this combination of enriched background and deeply stimulated neuroanimated foreground that Omar Ahmad invented at Carter to actually take advantage of all this neuroscience and all of this medicine. So I hope that you can see, and I think I heard other people mention it, that you're going to need to have artists, computer scientists, software and hardware engineers basically creating these enriched high dose, high intensity experiences so we can actually begin to take advantage of the neuroscience knowledge that I've tried to tell you about. And they're going to have to run hand in hand so that we don't just work out the mechanisms, but we actually have large effect sizes at the level of impairment. And I'll stop there. Thank you very much. I think I kind of went over, but I don't care. Thank you. Bye.